Respiratory centers are affected by chemical factors, higher brain centers, and the pulmonary irritant reflexes, including the inflation reflex. Chemical factors are the most important of all factors influencing the depth and rate of inspiration. The rate and depth of inspiration are affected by pCO2, PO2, and pH. These levels are sensed by central chemoreceptors in the brainstem and peripheral chemoreceptors in the aortic arch and carotid arteries. pCO2 is the most potent and closely controlled influence on breathing rate and depth. If blood pCO2 levels rise, as in hypercapnia, carbon dioxide accumulates in the brain and joins with water to become carbonic acid. Carbonic acid dissociates, releasing H+, causing a drop in pH or increased acidity. Increased acidity stimulates the central chemoreceptors in the brainstem, which synapse with the respiratory regulatory centers. The respiratory centers increase the depth and rate of breathing, which lower the blood CO2, and the pH rises to normal levels. If blood pCO2 decreases, the opposite occurs. Respiration slows and becomes shallow. Apnea is breathing cessation that may occur when pCO2 is abnormally low. Swimmers sometimes voluntarily hyperventilate to enable themselves to hold their breath longer. This causes a delay in respiration, and pCO2 levels need to be built back up. This may be dangerous to the swimmer. Figure 22.26 shows how pCO2 regulates ventilation by negative feedback. Increased pCO2 decreases pH in the brain, which is picked up by the central chemoreceptors in the brainstem. Also, peripheral chemoreceptors recognize the increased pCO2 increase. The afferent impulses from the chemoreceptors are sent to the medullary respiratory centers, which send efferent impulses to the respiratory muscle to increase ventilation so more CO2 is exhaled. The arterial pCO2 and pH return to normal. Hyperventilation is increased depth and rate of breathing that exceeds the body's need to remove carbon dioxide. Excuse me. This may be caused by anxiety attacks and leads to decreased blood carbon dioxide levels or hypocapnia. Hyperventilation causes cerebral vasoconstriction and cerebral ischemia, resulting in dizziness and fainting. Early symptoms include tingling and involuntary muscle spasms in the hands and face. The treatment is breathing into a bag to increase carbon dioxide levels being inspired. Peripheral chemoreceptors in the aortic and carotid bodies sense arterial oxygen levels. Declining PO2 has only a slight effect on ventilation because there is a huge oxygen reserve bound to the hemoglobin. A substantial drop in arterial PO2 below 60 millimeters of mercury is necessary to stimulate increased ventilation. Excited chemoreceptors cause respiratory centers to increase ventilation. pH can modify respiratory rate and rhythm even if carbon dioxide and oxygen levels are normal. Peripheral chemoreceptors detect increased pH. Decreased pH may indicate carbon dioxide retention, accumulation of lactic acid, or excess ketone bodies. So the body responds with increased respiratory rate and depth. Higher brain centers also influence breathing rate and depth. The hypothalamic controls act through the limbic system to modify the rate and depth of respiration. For example, holding your breath in anger or gasping with pain. Additionally, temperature changes also change the rate. Cortical controls are direct signals from the cerebral motor cortex that bypass medullary controls. For example, holding your breath lasts only until the brainstem reinstates breathing when blood carbon dioxide levels become critical. Pulmonary irritant reflexes also affect breathing rate and depth. Receptors in the bronchioles respond to irritants like dust, accumulated mucus, or noxious fumes by reflexly constricting air passages. Receptors communicate with respiratory centers via the vagal nerve afferents. The irritant can trigger a cough in the trachea or bronchi, or a sneeze in the nasal cavity. The Herring-Brewer reflex, or inflation reflex, is when stretch receptors in the pleurae and airways are stimulated by lung inflation. They send inhibitory signals to the VRG and DRG to end inhalation and allow expiration. This may act as a protective response for more than a normal regulatory mechanism. Figure 22.25 summarizes the neural and chemical influences on the brainstem respiratory centers. Respiration is also adjusted during exercise to provide for the body's metabolic needs. Hyperpnea is increased ventilation. PO2, PCO2, and pH remain constant during exercise. The abrupt increase in ventilation occurring in exercise involves three neural factors. The psychological stimuli of the anticipation of the exercise. The simultaneous cortical motor activation of skeletal muscles and respiratory centers, and the excitatory impulses to the respiratory centers from proprioceptors and moving muscles, tendons, and joints. The gradual increase in plateau of respiration is caused by increased rate of carbon dioxide being delivered to the lungs. Ventilation declines suddenly as exercise ends because the three neural factors end. The gradual decline to baseline is due to the decline in carbon dioxide flowed after exercise ends. Exercise leads to anaerobic respiration and the formation of lactic acid. The lack of oxygen in muscles is not from poor respiration, but from insufficient cardiac output or skeletal muscle inability to increase oxygen uptake. Traveling to high altitudes above 8,000 feet results in lower atmospheric pressure and PO2 levels. One may experience headaches, shortness of breath, nausea, and dizziness. In severe cases, lethal cerebral and pulmonary edema may occur. Respiratory and hemopoietic adjustments are made with long-term moves in high altitude. This is called acclimatization. Chemoreceptors become more responsive to PCO2 when PO2 declines. A substantial decline in PO2 directly stimulates peripheral chemoreceptors to increase minute ventilation that stabilizes in a few days to 2 to 3 liters per minute higher than at sea level. High altitude conditions always result in lower than normal hemoglobin saturation levels due to less oxygen being available. The decline in blood oxygen stimulates the kidneys to accelerate the production of EPO, or erythropoietin. The red blood cell numbers increase slowly to provide long-term compensation. This is sort of like a natural blood doping, so athletes often train in the mountains so their bodies have more red blood cells and oxygen carrying capacities. Now we will move on to cover some lung diseases. Chronic obstructive pulmonary disease, or COPD, is a combination of emphysema and chronic bronchitis, with a key feature of irreversible decrease in the ability to force air out of the lungs. It also includes asthma as part of its definition. Other common features of COPD include a history of smoking in 80% of the patients, dyspnea or labored breathing, also described as air hunger, coughing and frequent pulmonary infections, and most patients hypoventilate, which results in respiratory acidosis and hypoxemia. Emphysema is part of COPD. Emphysema is a permanent enlargement of the alveoli and destruction of alveolar walls that result in decreased lung elasticity and 3 consequences. First, accessory muscles are necessary for breathing, leading to exhaustion from using 10 to 15% more energy to breathe than normal. Secondly, trapped air causes hyperinflation, which flattens the diaphragm and causes an expanded barrel chest, both of which reduces ventilation efficiency. Lastly, damaged pulmonary capillaries lead to an enlarged right ventricle. Hereditary factors may increase one's probability to develop emphysema. Here we see alveolar changes in lung diseases. With pneumonia, alveoli are filled with fluid, so gas diffusion must cross a thicker area, leading to lower PO2. In emphysema, the alveolar membranes break down, resulting in large alveoli storing oxygen, less surface area, and the hyperinflation of the lungs. The graphic on the right shows signs and symptoms of someone with emphysema. They are often viewed as a pink puffer, have increased CO2 retention resulting in pinkish skin, minimal cyanosis, pursed lip breathing, dyspnea, barrel chest, prolonged expiration time, and the use of accessory muscles to breathe. They have a thin appearance. The other part of COPD is chronic bronchitis, which may be due to inhaled irritants causing chronic excessive mucus, leading to inflamed and fibrosed mucosa of the lower respiratory passageways, and ultimately obstructed passageways or airways that impair lung ventilation and gas exchange. Symptoms include frequent pulmonary infections. Risk factors include smoking and environmental pollutants. On the left picture, we see how chronic bronchitis causes inflammation in mucus, which will block any gases from getting to and from the alveoli. On the right graphic, we see signs and symptoms of a chronic bronchitis patient, who we sometimes refer to as a blue bloater. These patients have a dusky to cyanotic color, recurrent cough, increased mucus production, hypoxia, hypercapnia, respiratory acidosis, increased hemoglobin and respiratory rates, exertional dyspnea. Chronic bronchitis occurs more frequently in heavy cigarette smokers and may lead to cardiac enlargement, use of accessory muscles to breathe, and often they will be seen using an oxygen tank. COPD symptoms are due to the patient's innate respiratory drive. Pink puffers are usually thin because they burn large amounts of energy breathing, and near normal blood gases are maintained so skin color is normal. Blue bloaters are usually stocky and have cyanosis due to hypoxia. COPD treatments include bronchodilators, corticosteroids, oxygen, and sometimes lung volume reduction surgery. Figure 22.28 illustrates the pathogenesis of COPD. Tobacco smoke, air pollution, and alpha-1 antitrypsin deficiency lead to continual bronchial irritation and inflammation, and the breakdown of elastin in the connective tissue of the lungs. These lead to chronic bronchitis with excess mucus and chronic productive cough, and emphysema with alveolar wall destruction and the loss of lung elasticity. Both conditions are definitive of COPD, leading to airway obstruction, dyspnea, and frequent infections. Lastly, they lead to hypoventilation, hypoxemia, and respiratory acidosis.